So we engaged a friend from Florida, Dr. Bruce Cohen, who is going to be stepping in for Dr. Davidson to give the talk on routine foot care is certainly not routine. And we have to thank Dr. Cohen in advance, since he stepped in at the last moment with somebody else's slides, but I'm sure that he's going to do just a fine job. So let's welcome Dr. Cohen.
Good morning, everyone. So we're going to talk about routine care when it's not really routine care. Podiatry started with chiropody, and these days everyone gets their 3-year residency and they know how to do surgery. But the bread and butter of podiatry is not really surgery all the time. You'll get patients that need their nails cut. That's called routine care. And we all know many ways to treat feet, and this is not routine. This is a diabetic foot. To us, this is routine. But to the world, this is a diabetic ulcer. And there's different ways to treat them. You can debride with a scalpel, you can debride with maggots, you can debride with lasers. The bottom line is good wound care is important. You know that. But we're going to talk about diabetes. So who's at risk for diabetes? Well, diabetic foot complications are the single most common cause of non-traumatic lower extremity amputations. The most common start for amputations is the diabetic ulcer. Now, I've never seen these slides before, so this is new to me too. Okay, so who's at risk? It's hard to complain of pain when you don't feel it. And that's one of the problems with diabetes. You know, it's diabetic neuropathy. Put it all up there. So the main thing to treat patients is prevention. Let's face it, once you get the ulcers, it could be a path to amputation. So prevention is the key. The goals of care are to reduce complications, including ulcerations, hospitalizations, and amputations, improve the quality of life for people with diabetes, and try to reduce the healthcare costs and non-healthcare costs associated with diabetes. In 2011, the results of the Thomson-Reuters healthcare study showed that there's a 3-year period that was examined. 1 year before an ulcer, 2 years following the ulcer. Patients with commercial insurance had a savings of almost $20,000 when podiatry was used. And with Medicare, there was a savings of over $4,000 when podiatrists were involved in the treatment. There was a Duke study done from 1991 to 2007. The objective, obviously, was to determine the effectiveness of care from podiatrists and lower extremity clinicians. The conclusion of the study: there was a significant reduced amputation rate if the patient was seen by a podiatrist at least once during the 1 year prior to the ulcer, and with the time period of 2 years after the ulcer. So the results were most favorable to a combination of care involving the combination of podiatrists and lower extremity specialists. Now I'm going to skip some of these slides because some of this, to us, this is routine care, but the truth is, to the world, diabetic foot care is not routine. So in my head, when we talk about routine foot care, that's a 20-year-old that comes in that needs their nail cut. And the diabetic that has vascular compromise, that's an at-risk foot care patient. It's not routine. Patients that have nails like this are not routine. To us in our office, yeah, it's routine because this is what we do. We're specialists. But to cut a nail like that on a diabetic patient, you better have the right equipment. Not most patients, but many patients have the neuropathy and they have no sensation. This patient came in merely to have his toenail cut. He didn't feel the ulcer. So he thought he was getting his toenails cut, and he definitely had a problem. This is another toenail. How do you cut this with old-fashioned instruments? You can't. You have to really be a little bit on the modern side. Secondary infections with diabetes. If a patient had onychomycosis, you can see there was a lot more gangrene found, a lot more foot ulcers were seen. So you do want to treat the onychomycosis. You have to do more than just cut the toenail with a clipper, and to use an old Dremel, that's not the way to do things. But who qualifies for the at-risk foot care? Well, you have to have the qualifications. So you have your Class A findings. Any type of a non-traumatic amputation qualifies automatically. You need one. Now for Class B, you need 2 of those findings. The absent posterior pulse, you need absent dorsalis pedis pulse, and you need advanced changes. Most diabetics have at least one of them. So if you have one of them, you will have to have 2 of the Class C findings, which is claudication, temperature changes, edema, paresthesia, and burning. So what happens when you put a toe like this into a shoe? You know what happens. You get subbungual problems. So you have to be able to cut the nail properly to get that junk out. Now, why not use a Dremel? All electric drills create an aerosol of bacteria and fungus and remain in the air for up to 30 minutes. The high-speed drills of today are great, but they do release the potential for getting hepatitis B, hepatitis C, HIV. Dremel drills recently have been banned from the VA for that reason. So the VA says, if you're going to grind, you need some type of a vacuum device to get the mist. OSHA recommends also having a vacuum device. This is a picture, it's hard to make it out, but it's the dust that gets shot into the air that you breathe in after you grind nails. These dust particles are small enough to deposit in the alveoli, bronchioles, and throughout the respiratory system. So it's been shown that podiatrists have 4 times the national prevalence of asthma, and there was a Miller postal questionnaire which showed 39% of podiatrists had rhinitis or allergies, 51% had eye problems, 18% had chest complaints, and 22% had skin problems. There was a 2008 guidelines written for infection prevention and control by an antibiotic task force. The purpose of their study was to make guidelines. It was targeted to the general family practice and to podiatry offices. The Centers for Medicare and Medicaid Services define routine foot care as the cutting of and removal of corns and calluses, the trimming of nails, and other routine hygienic care. But when a patient comes in with the onychomycotic nail, that's not routine foot care. But they put in writing that there is an appropriateness for the room. So what's appropriate? Any room is appropriate for routine foot care, the trimming of nails, corns, and calluses. But a separate room should be dedicated to sanding and burring. And that's tricky. It's because of the aerosolization, contamination environment, the equipment that supplies that room, it's there. And it builds up patient after patient. So they recommend to set up the room to make it visually clean and organized, to cover exposed items when sanding, remove or minimize room equipment, turn on an air filter, and use a sanding vacuum. There are a lot of vacuums out there associated with burrs. This particular one is being shown outside, and it happens to really be what you need because it has a great vacuum. There are special burrs that they have for diabetic care. They have a set of diamond burrs and carbide burrs, and B&A Burrs has their drill FDA registered. That's important because if asked in a court of law, what did you use? If you say Dremel, you've lost. So you really, in today's world, you have to have today's equipment. A Dremel drill doesn't make it. The advantages of a drill with a vacuum, obviously, it sucks up the debris. The BNA burrs machine collects 90% of the dust, but it's still recommended to wear a mask because the 10% is still going to be there. But 90% of vacuum is great, it really is. It has auto gripping, the burr goes in easily, it's lightweight, it's very easy to hold on to, it's not unbalanced like a Dremel. It's really something you should just try and feel, because in today's world, the cable drills that the dentists used to use, you won't find that in a dental office anymore. And Dremels, you shouldn't find them anywhere anymore. Okay, so in January of 2014, the American Diabetic Association printed these recommendations. They recommended once a year a comprehensive foot exam. So that would evaluate risk factors and protective ulcers, and it will decrease amputations. You want to inspect for lesions. You check for assessment of pulses. You check the neurologic exam by using a 10-gauge monofilament wire. You check vibration by using a tuning fork. Pinprick sensation, ankle reflexes, and vibration perception should also be checked. To go over it quickly, to use a 10-gauge monofilament, you basically just push it into the foot at a couple of spots designated by the red dots, and you see if the patient feels it. It's a very high-tech test. So there are other recommendations they made. You want to provide general foot self-education. Using the multidisciplinary approach, don't be ashamed to refer out. If you have a patient with poor circulation and you don't refer them out, shame on you. You want to refer patients that need help if you can't handle them. Ongoing diabetic prevention, you want to inspect the skin, you want to teach the patient to inspect himself. You want to provide offloading plantar pressure, debriding callus, we all know about orthotics, debriding hypertrophic nails, and patient education. So one last remark. We are podiatrists, and we have to look classy. These types of machines, the drills with the vacuum, they are being bought by pedicurists and by spas.